canine or cuspid. So cuspid, I'll accept canine. I won't accept wolf, okay? Or fang. But my husband's cuspids hang down a little bit longer than the, he doesn't look like a werewolf or whatever, but they hang down a little bit more on each side, and that's why they're called that. So these are all present in children. And then as we get to adulthood, we see two new ones. These are the first and second premolars or bicuspids. And again, I'll accept either term. Then the child has a single, first it has two molars. I guess I should start bringing this back in again. And with the adult, we add a third molar. The reason I drew this one in red is because it causes a lot of pain. The third molar is known as the wisdom tooth, and because it comes in later, I guess, when you're older. The reason it is typically a problem is sometimes the jaw is too short for it. It can come in sideways and push on the roots of the second molar, or I don't have any at all. So even if you do x-rays, I don't have any third molars. I still had 4 teeth pulled because I needed braces, and even after the braces were taken off, my lower incisors still overlap. They should have put a permanent bar in the back, and that didn't happen. But so with the 3 that are in color, that brings our total up to 8. We have a series of models over here that show teeth at various stages. So here. And then a couple of mandibles. These are rolled bone mandibles. These are bones. All right, so be able to identify whether a tooth is part of adult dentition or child dentition and be able to name it. Salivary glands. These are, along with teeth, but these are also in the tongue even. These are considered to be accessory organs. Now on Tuesday, we will talk about accessory organs as well, and the liver and the pancreas. Right? Accessory organs are accessory when we talk about the digestive tract again, not because they're not needed or they're just kind of there for decor, but because the food doesn't directly pass through them. They're not the tube itself. All right, so you wouldn't be able to live without your liver or your pancreas. So they're not accessory in that sense of function, but definitely food doesn't leave the small intestine, go up into the liver, and then come back into the small intestine. So they're accessory to the tube itself. All right, so salivary glands are an exocrine gland. They actually, I'm going to erase the teeth in a moment there unless you need pictures. They are connected to the oral cavity via ducts. And unfortunately, as we move away, now some of these eponyms I still give you. So like the, we still talk about the bundle of hits, all right, where we talk about things, the loop of handling. But we're so far away, nobody ever refers to these ducts by their eponyms. The parotid duct used to be Stinson's, and submandibular was Wharton's, and sublingual were ducts of Revenus. I could actually write lecture questions out of that. which of the following ducts is associated with the parotid gland? It's kind of like, when was the War of 1812? Well, the parotid duct is associated with the parotid gland. It's kind of a pointless question. But I do want you to know their locations. So the parotid gland is large and just anterior to the ear. That's where we get the word parotid, next to the ear. And it is the primary watery secretion. So if you're chewing gum, or you're smelling brownies baking, and your mouth starts to water, that is a serous fluid coming from the parotid gland. So the parotid gland sends its duct anterior over the buccinator muscle, and it penetrates through the mucosal lining of the mouth and empties into your mouth just opposite the second molar. If you take the tip of your tongue, and I don't have a picture of it here, but take a picture of your tongue. If you take the tip of your tongue, kind of run it along the inside of your mouth opposite your second molar, you might feel a little bit of a bump or papilla. When you're bored during the next exam, you can massage that and get saliva to come out. A couple years ago, students brought me YouTube videos of kids, teenagers, squirting saliva from their sublingual glands and just coming out 7 or 8 feet or so. We're not going to have a contest doing that. But that saliva is a little bit thicker. So this is a watery serous secretion, and it is the primary gland that releases our digestive enzymes. So next week when we talk about physiology, we'll come back to the mouth and we'll look. We have salivary amylase, we have salivary lipase. These are enzymes that start the breakdown of lipids and starches. Then we have the submandibular gland, which is kind of J-shaped. The lower part of the J starts on the outside of the mandible, and the rest of the J runs around the inside of the mandible. And this one is mixed. It is primarily serous, but it also produces mucus. So that would be it, this gland here, and its duct comes up kind of into the side of the mouth. And then right under the front of the mandible, under the tip of the tongue, with multiple ducts, we have the sublingual. And this one is mucus. So the mucus portion helps to bind your food together. So let's say you're chewing crackers, right? And this helps to stick it together so you don't have cracker crumbs flying everywhere. Keeps it so you can move it from side to side in your mouth as you chew it. So when we look at this one, which of these would you expect you're looking at? The parotid, the submandibular, or the sublingual?
The sublingual?
Not sublingual. Most of it is serous. That's the purple cells that you see, very similar to the pancreas, by the way. And then just a small amount, at least from what we can see in this slide, of mucus. When we look at sublingual, it's going to be 90% at least mucus cells. So I have one of the last slides, I have that. Okay. So I put that one up there because it has all of them in there. So the parotid is going to be all the purple ones. So these are what we call acinar cells. Have a purple marker. So the parotid glands are going to have these pie-shaped, they're really pyramidal in the sphere, but when we cut them, they're pie-shaped. similar to the pancreas. So these are known as acinar cells. Okay, that's the serous. The mucus cells are in clusters with a white, kind of, they almost look like sebaceous cells. So they're not goblet cells, but they do contain mucus proteins. And then, especially in the sublingual, where we have primarily mucus cells, you will see what are called serous demilunes. You'll see a purple cell forming kind of a cap on part of the mucus cells. And that's described, a demilune is like a half moon, a crescent. So those are serous demilunes. All right, so before we leave the mouth, let's go back to looking at the wall as it relates to our general structure. So remember when we talked about the general plan of the alimentary tract, we had the mucosa, and below the mucosa we had the submucosa, and then we had the muscle layer, the muscularis externa, and then the serosa. So in the mouth, the mucosa, what would be the epithelium of the mouth? Non-hornified, stratified squamous. We're going to have loose, irregular connective tissue as our underlying connective tissue, but there is no muscularis mucosa. We only see a muscularis mucosa when our muscularis externa is smooth muscle. Submucosa is just standard, just irregular connective tissue. Muscularis externa is going to be the skeletal muscle of our cheek and face. So the primarily the buccinator and masseter. All right, and our serosa?
Skin.
Skin. So I just have a summary of the digestion. So up there on Thursday, we'll come back and talk about the enzymes that are released and so on. Primarily mechanical digestion. We don't break any food substance down into something small enough to be absorbed. So typically a little bit of water, even across the non-hornified, stratified squamous, it's not much. Drugs, so the nitroglycerin type drugs, sublingual drugs that you can put that are lipid soluble, to be able to cross the membrane. Most of us don't eat simple sugars and amino acid droplets and stuff like that, but food stuff is going to get across. Okay, let's do the esophagus and then we'll take a break. Can I erase the wall? Yeah, I'm drawing all over the wall. That's the other classroom, I forgot. All right, so we talked about the pharynx already with the respiratory system, so I'm not going to go back over that. But when we swallow, food is pushed, this is called a bolus. food that we chew, we've chewed it, gets pushed back into the oral pharynx, and then the swallowing reflex starts, and skeletal muscle and then smooth muscle moves it oral pharynx down into laryngopharynx, and then the esophagus takes over, all right? As I said on Tuesday, if you know that first part of the esophagus is skeletal muscle, we haven't developed much voluntary control over it. It still works as a reflex. You might be able to start to gag on something and cough it back up again that you don't want to swallow, but you can't typically start swallowing at the esophageal level. All right, you can trigger that by the voluntary movement of your tongue and so on, your upper pharynx, your oral pharynx. But the esophagus itself, you can't say, I'm going to start peristalsis of my esophagus and begin it at that point. Most of you are familiar with the structure of the esophagus. It functions primarily as a tube that connects our pharynx to the stomach. There is really nothing that happens in this tube unless it got started in the first place in the mouth. All right, so if you chewed long enough to mix the food up with salivary enzymes, any digestion that's taking place here is going to be what is occurring for a few moments with the enzymes from the salivary glands. In this structure here, you can see that we're continuing the mucosa of the mouth. Probably could just lift that up there. So we have, see my colors here. So we have non-cornified, stratified squamous epithelium. We have a loose irregular connective tissue. That's all the way down, right? Now in the upper third, there is no muscularis mucosa because it's all skeletal muscle for our muscularis externa. In the middle third, it's patchy. It begins to show up, but it's not complete. Okay, so it's here and there. As we start to mix the skeletal muscle of our muscularis externa with smooth muscle. And then in the distal third, we do have a muscularis mucosa present. Okay. And we're going to have muscularis mucosa now all the way through the rest of the digestive tract until we get to the anal canal. So mucosa is still our standard dense irregular connective tissue. Except at the lower distal couple of inches. All right, so most distal we do have present submucosal glands to protect from the acid splashing from the stomach. So again, these are secreting mucus. They're not goblet cells. They're mucus glands, like our mucus sublingual cells, protecting secreting mucus. And this is where we see the most distinctive changes. So as I indicated up here, the upper third is going to be skeletal muscle. The middle third is mixed. And the lower third is all smooth muscle, the intercircular outer longitudinal pattern. So here you're seeing the the mucosa with the non-cornified, stratified squamous, and loose irregular connective tissue. And that's what you see here, right? The submucosa. And then the muscularis externa. Here is showing smooth muscle, so there's patchy muscularis mucosa. It's a little hard to see right along here, but there's patchy muscularis mucosa. Now, we're not in the abdominal cavity. We don't have peritoneum in the thoracic cavity. The pleura isn't associated with the esophagus, nor is the pericardium. So we don't have a serous membrane wrapping around the esophagus. We just have an outer layer of dense, irregular connective tissue similar to what we find with blood vessels. Well, we call it the same name, so an adventitia. Now, some babies are born. Remember the esophagus, the trachea is an outgrowth of our digestive tube. Some babies are born with the esophagus coming down like this and either narrowing or not even connected to the stomach. Okay. So depending on the diameter of that, of course, it's going to be dependent on the severity. So this is known as esophageal atresia. What do you think is the primary sign of this? Hey, baby.
Spitting up?
Not just spitting up.
Like, oh, projectile.
Projectile vomiting. All right? Or they don't just throw up a little bit like they might if they didn't get burped properly or whatever. A little bit of spit running down daddy's shoulder or something. Within 5 to 20 minutes after eating, it's 10 or 20 feet of vomiting. So that's the projectile vomiting that is indicated. So that projectile vomiting is a classic sign. Doesn't mean this is the only cause, but in a newborn, it's what they will look for. So when my son was 7 months old, we took him in to have his mouth repaired, and shortly after he came back to his room from surgery, they had an admit of a baby that was about 4 days old with esophageal atresia. It wasn't the absent esophagus. In that case, what they would do is, of course, to get feeding to the baby, they'd have to put in a gastric tube, which is just a basic simple tube into the stomach wall, and then feedings are given with formula via just a small syringe. So, every 2 or 3 hours or so. With the narrowing, they will measure the diameter, and if they have a series of ratings. If it's large enough, they won't do anything. They'll just let it be that way for a while. If it's small enough, if it's below a certain parameter, obviously what we see here, then they will do surgery, almost like doing a stent for a carotid artery blockage. They'll go in there and put in a mesh-like structure and stretch it out. Now, that's multiple surgeries. So when Will went back, actually when he was in at just 4 months of age, when they put tubes into his ear, there was a 3-year-old parents who were in the waiting room with us, and he was in for like his 3rd or 4th surgery to have the stent-like stretching occur. Okay, so with this newborn, they determined it was narrow enough that they needed to go in and do the surgery to stretch. Okay, so let's stop here and take a break. I know we got started a little bit late, but this is a good place for a break before we put, I'd like to do the stomach today and